All right, guys, I think we probably have a good amount of people here and we're ready to get started. I am Dr. Lauren Sundheimer. I am a double board certified reproductive endocrinologist with Kindbody. My home base is in Newport Beach, California, but I'm also helping out a couple other places. And tonight we're going to be talking about Fertility 101 and understanding your hormones, something I'm sure we all heard about, know about, need to know more about, etc. If you want to follow me on social media, I would love that. It's at Sundheimer MD, and I'm more than happy to share random updates with you and little tidbits, education, etc. And I'm also happy to cheer you along on your fertility journey as well. Our mission at Kindbody is to kind of revolutionize fertility care. We are so focused on you, on your treatment, on your best outcome, having you have the best experience, getting the best treatment, having the most superior pregnancy rates, success, etc. We want it to be a unique, special experience, just as unique and as special as you are. And so we're really trying to change the landscape of how fertility care is delivered. We see each other as a family. We're a community. We're growing one baby at a time, and we're here to support you on your journey throughout. So as for what we do at Kindbody, we kind of do it all. And this is a really busy slide that goes through all of what we do, probably missing something too, but our focus is mainly on fertility. So we do fertility assessments for men and for women. We do virtual and in-person visits to talk with an REI or a reproductive endocrinologist infertility physician that focuses specifically on infertility. We do IUI, IVF, we do PGT, which is pre-implantation genetic testing on embryos. For those of you that don't know, IUI is intrauterine insemination. And we'll talk about a variety of these things, obviously, tonight. We do egg and sperm freezing, embryo freezing. We're helpful in the LGBTQIA community. We help with male reproductive health. We do genetic testing. We have at-home fertility testing. We also, aside from all that, do a lot of counseling and support. So again, LGBTQ support. We have our own in-house third-party programs for fresh and frozen eggs. We have egg donors. We have gestational surrogacy. We focus a lot in wellness and reproductive health, but also nutrition and mental health for a variety of conditions. There's so much that goes into getting pregnant, staying pregnant, having a baby, delivering a baby. There's a lot that goes into it. And like I said, we're here to support you each step of the way. So we're on the journey with you. And I think one of the biggest take homes you could get today is that fertility and reproductive care are so important. And one of the most important things in it is time. So fertility is affected by time. Your overall fertility health goes down with time. So whatever you can do to kind of take that first step, which you're doing today, and I congratulate you, is helpful. And learning about things, knowing things, figuring things out is a journey. And you're here taking the first step, and getting the knowledge is something very powerful. And so, just kind of taking a step back, Fertility 101. Okay, so I learned the basics. Why is this important? And it's important because our whole lives we're taught how not to get pregnant. And then once it's time to actually start, people are like, wait, where do I begin? And so this is kind of to help set the stage. And we're going to dive a little bit deeper into some of the hormones and various things about what's important as you're on this journey. So again, going back to one of the most important takeaways is that time is important, and that's really has to do with your age. So age is the most important factor when it comes to fertility. And obviously you can't go back in time. And so you're just here where you're at, which is why we always encourage people to start thinking about this at your youngest possible age. As women, we're born with a set number of eggs, and that's all you're ever going to get. So you have about 2 million, and you actually start losing them while you're still in your mom's pregnant belly. And so by the time you go from your 2 million and then you lose them. And by the time you actually have your first period and you're in puberty, you only have like 300, 400,000 eggs left. And then from there, you continue to lose eggs each month. And if you're on birth control, if you're having a period, if you're not having a period, whatever may be the case, you still lose about 1,000 eggs every month. That group is kind of pre-selected, and whether you use it or you don't, you lose those eggs. And so that's why age is important, because you start losing those eggs. And as you get older, you lose more of them. Oftentimes you'll hear people talk about 35 as being this like big important age. And it is important, yes. That's because at 35, that's when you start to typically see a more significant decline in fertility in terms of egg quantity as well as quality. But it's not a light switch. It doesn't just go off and on and like, oh, 1 minute you're fine, the next minute you're not. It's something that can go down gradually with time. And even women who are under 35, in fact, 1 out of 10 women have low ovarian reserve or lower numbers even before age 35. And that's why we really encourage you to kind of think about this, look into this, because you would want to know if you're on that lower side at a younger age, or even if you're at an older age on the lower side, you want to maybe be a little bit more aggressive, knowing that time is really important. And so it's both the quality and the quantity that matter. So as we get older, the number goes down in terms of actual quantity of eggs that we have, but also the quality of the eggs. And by that, I mean the genetic health. So the eggs, because we've had them our whole lives, they're just not as good as, when you're younger. And so that can lead to poorer egg quality. It can lead to miscarriage or having genetic issues in the egg and ultimately the embryo. And so it's not anything that we can necessarily correct, but we just keep it in mind and we move forward and we try and just get the best that we can get, whatever stage you're at. And so, thinking about it, you're never too old, you're never too young. We're here to help you each step of the way, and being proactive, being here today is what you can do to do this journey and to be, taking those first steps. And so starting at the very most basic time, when are we even fertile? When do we start trying to get pregnant? And so if you're having regular menstrual cycles, you're probably ovulating regularly. And so in a classic 28-day cycle, which most women do not have a perfect 28-day cycle, but for purposes of illustrating the point, if you have a 28-day cycle, you're probably ovulating somewhere in this 10, 11, 12, 13, 14 day. Ovulation in this calendar is the yellow dot, and the fertile days are the few days preceding it. And so the way that we count things in the fertility world is your period starting the first day of full flow bleeding is considered day 1. And so if you're wanting to try and get pregnant, and then you're going to kind of calculate from that day 1, days 10 to 14 or so, and having intercourse every 1 to 2 days during that fertile time yields your highest chance of pregnancy. And so if you think about it, it's kind of crazy. We're only fertile for like 5-6 days out of the month, so you really have to time it. It is really important. Time is, again, important, not just for your age, but also to track your cycles and where you're at in your cycles and when to time your intercourse. And so it's not just, pure egg numbers, egg quality, all those things. The environment is also important. And so your everyday routine, the environment, lifestyle factors, etc., all influence things. That being said, birth control pills do not negatively impact your fertility. But you want to make sure that as you're going along, you're eating a good diet, you have a good lifestyle, you're getting some good exercise, sleeping well. You want to pay attention to your family history. Maybe your mom went through menopause really early or had multiple miscarriages or whatever may be the case. It's important to kind of tap into these things. And then I'm also a really big proponent of taking care of your mental health. I think, being in your best mental, emotional, physical health, spiritual health, whatever may be the case, the best state of health that you're in leads to the best outcomes across the board. And so I'm a big proponent of that. As far as kind of infertility and what does that mean? That is the inability to get pregnant or stay pregnant after 1 year of trying when you are under the age of 35. Again, because of that 35 number, because we know that it becomes a little bit harder to get pregnant and to have normal eggs, etc., we do use that as a cutoff point. So if you're over 35, then you don't want to keep trying for more than 6 months. We want to try and be a little bit more aggressive so that we don't waste time. But that being said, infertility is fairly common. About 1 in 8 couples have infertility, and it's not always just the female. We talk a lot about eggs and many women are on this call, but about a third of the time it's due to the guy. And so it's really important to not just have the female assessed, but also the male, because we want to make sure that we're not missing a big proportion of what could be going on. At the end of the day, like this says, there's no magic formula. Everyone is different. Everyone's journey is different. The only way to really know where you individually stand is to have a visit, to get some testing done, to do the assessment and figure out where you're at. And knowledge is helpful. It's good to know where you stand, even if you're not ready right now. At least you know, based on today's data, I'm in a good place. The testing we have does not tell us if you're able to get pregnant easily or not. We can just check to see, do you have eggs? Is there sperm, etc. But that in and of itself, I think, is a very valuable thing to know. So as far as kind of what to do, schedule your first visit. So usually we can do our one-on-one visits virtually. So Zoom has been great, especially with the advent of COVID times. But it's really nice because you could do it from the comfort of your own home. You talk one-on-one with a fertility doctor. We would go through your history, your family planning goals, talk about what kind of tests to do, what your plan should be, and kind of, tailor really what would be best for you based on that conversation. Then to follow that, after that initial chat, usually you're going to come in to do the test. So that's a transvaginal ultrasound. That's the best way to look at the ovaries. We can count up the little follicles in your ovaries, which are little black circles, and they kind of look like chocolate chips in a chocolate chip cookie. But they house the microscopic eggs, so we can actually get a count of your follicles in that given month. And then we also want to do some blood work to see how your body is doing hormonally. So the theme of the talk tonight is kind of what the hormones are. What are they doing? One of which is your AMH, which I'll talk about in a little bit. Oh, and here we are. So your AMH stands for anti-Mullerian hormone. And this is a great blood test. It can be done at any point in your menstrual cycle, and it helps us estimate kind of your follicle count in your ovaries, or the number of eggs that can potentially be available. It does not change with your menstrual cycle, unlike some of the other hormones that are dependent on where you're at in your cycle. This test can be done at any point. So all of these are blood tests, but this can be done at any time. It should relatively be stable. It can actually be done on birth control even. So if you take birth control pills and you're trying to just decide where you're at, you might want to consider having your AMH checked to see where you're at, in addition to doing a follicle count. That being said, sometimes it can be a little bit on the lower side. So if your level comes back abnormal, talk to your doctor about what that means, if maybe you should stop the birth control for a little bit, or, if you don't need to, or whatever may be the case. But it is a really helpful test that we can do on birth control, not on birth control, at any point in your cycle. It gives us kind of a gas gauge of where you're at. Are you on the high side, the low side, kind of on the normal side? The next kind of big hormones that I want to talk about are FSH, or follicle stimulating hormone, and then estradiol. It's also abbreviated as E2. So FSH is a follicle stimulating hormone, and it does exactly just that. So it's a hormone that's released from your brain to talk to your ovaries, and it says, hey, ovaries, grow a follicle. And so the follicles, like I said, we see them on ultrasound. They're a microscopic egg inside, and you have a pre-selected group of follicles that are ready. That FSH hormone gets secreted from your pituitary gland in your brain to grow one of those follicles. And so that becomes the main dominant follicle and the one that you ovulate. And it kind of tells us how hard your brain is working to talk to your ovary to get that to grow, because as that level goes up, potentially your brain is working harder, and it can potentially make fertility treatments a little bit harder. Going back to the estradiol hormone, that is a hormone that we check in balance with the FSH. So as your FSH level goes up, it kind of depends on your estrogen level, because your estrogen level is going to start going up as your body is growing an egg. And so if your estrogen level is high, that can make your FSH level go low. And so it's just a hormone that we check to look at the balance of things. But those are specifically timed with your menstrual cycle. So usually we want to check those on like the second, third, fourth day of your period, because as you get further into your period, those hormones start changing. And so we want to try and check them at the standard time so we get the best representation. Another hormone that you'll hear a lot about is LH, which stands for luteinizing hormone. And that is also a hormone that's released from the pituitary gland in the brain. And that's the signal for ovulation to occur. So for those of you that are checking ovulation predictor kits at home and peeing on the little sticks, we call those OPKs for short, but essentially it's looking for this hormone in the urine. And so how it works physiologically is once your estrogen level is at a certain point, that signals to the brain in a feedback loop that, hey, it's time to ovulate. And then that LH hormone surges, and that's the signal for ovulation. The other hormones that are listed on here are also important, but those are not as fertility specific. So your TSH is your thyroid stimulating hormone, and that affects ovulation. If that's off, you can have irregular menstrual cycles. Same thing with your prolactin level. If that's not in a good place, that can throw off your periods. And so checking these, if you're having irregular periods, is important. It's not necessarily something that is checked in everybody, but in certain cases, we will check these other ones. And then the free thyroxine is another thyroid hormone that goes along with the TSH. And so these are kind of the big ones that we look at because they all impact fertility in some way. And they really can, potentially, if there's something that's abnormal, if we correct it, it could change things. Sometimes it just gives us information about how we can expect you to do in fertility treatment or what it kind of means for your ovarian health. But they're all very important in terms of evaluation and understanding where your body is at. Again, the male also contributes. It's half the genetics. And so there are testing that we would do for the male as well. The most important test that we do for the guy is the semen analysis. So we got to check the sperm. And typically men don't really need a lot of these hormone testing if their sperm is normal. If the sperm is normal, then presumably, hormonally everything is doing what it should. The sperm is being produced, is being released, and then we're able to get an assessment from the semen analysis to look at the various parameters in it. If it comes back abnormal, then we usually go down this investigative route of looking at the hormones. Men have some of these same hormones, so they just act in different ways. And so the cutoffs are different and there's various, things that we look at, but just so you know, there are hormones that men and women share. Their function is similar to a degree, but the values and the way that it works is a little bit different. And so these are the various tests that we can do if needed, but the men generally do not need these types of hormonal testing like women. So kind of knowing all of the hormones and what they mean and what we check and when we check them, it's important to keep in mind that the path to parenthood is not always linear. You don't always get the visit, get your tests, have the right results, go on, get pregnant or anything like that. It is a roller coaster. It's a journey. Maybe you get thrown a curveball and your follicle count was really low. But that's why we're here. That's why we're here to help you, to talk to you about it, to talk about options and what it all means. And so you do have options. You can freeze your eggs. You can freeze embryos. Even if you don't have a partner, you can use donor sperm. That's called third party when you use an egg donor, a sperm donor, a gestational carrier. But for fertility treatments, there's IUI, which is intrauterine insemination, and there's IVF, which is in vitro fertilization. And so what does it all mean? So egg freezing is where we take your eggs out of your body, we grow them, we take them out, we freeze them, and they're frozen at that moment in time. So it doesn't guarantee that you're able to get pregnant or that your younger eggs will result in a pregnancy or an embryo or anything like that. But we're just preserving your fertility literally where it's at right now for use down the road. Things to think about as you're considering egg freezing is your age, how many kids you want. If you're older, then you're going to want to have more eggs to try and get that normal embryo. If you want a bigger family, then you're going to want to have more eggs because you're going to want more embryos to have more potential for children. You're also going to want to think about your age. How old will you be when you have your first child versus your last child? Maybe you don't necessarily need your eggs for baby number 1, but you want a large gap in between your kids, and maybe you need it for baby number 2. So there's a lot of different factors to consider. There's no magic number that guarantees that you get a baby or anything like that, but definitely something you can talk about with your doctor and come up with a plan that's best for you. So how does it work? Each month, as I mentioned, your body has a group of eggs that it selects and it has ready to go. Physiologically, your body will normally select one. But when we do the egg freezing process, same thing for IVF, the process is the same of egg freezing and IVF up to the point of fertilization. So when I'm talking about that, you can kind of extrapolate the two, but you're going to, instead of your body selecting one, we try and give you medications to grow more than just the one. We want to get as many as we can safely, and then we go in and we take them out. We give you the same kind of hormones that are released by your body. So that FSH, the LH hormone, those are actually medications that you're taking to grow the eggs. We give you higher doses than what your body naturally makes to grow more eggs than what it normally makes. And so it's really important you give yourself daily administered injections to keep those eggs growing. Typically, it takes about maybe 10 or 12 days or so. You administer the injections in your tummy usually. They're very small needles, kind of like when people give themselves insulin shots. And we would teach you how to use the medications, how to inject it, and you come in periodically for blood work and ultrasound to follow up and see how your body is responding. We stimulate your ovaries, we grow the eggs, we look at things at the right time, then we would tell you, hey, you're ready for what's called your trigger shot, which is the very last shot. And then we go in and we take those eggs out. So this is kind of a rough timeline. It's about a 2-week process, plus or minus. You are coming in for blood work and ultrasound, so we can check on you, make sure that things are going well. And you would have a tailored calendar to you. Part of our Kindbody way is we use a portal, which is really great communication. And so you would be able to have access to this, to your results, et cetera, so that you knew exactly what was going on for you. The egg retrieval is actually the procedure where we go in and we take the eggs out. So it's a fairly quick procedure. You are under anesthesia because we do poke a needle into your ovary to take out the fluid in the egg. So we want you to be comfortable. We don't want you squirming around or anything like that, but it is fairly quick. You do need a ride though, because you're getting anesthesia, you can't work, you can't drive, that kind of thing. But most people do really great. It's fairly quick. You probably want to plan to kind of recover for a little bit thereafter. And again, we go into details at your full visit, but just so you have a sense, it's a really great option. It's about a 2-week process. Once you start the shots, you preserve the eggs so they can be used in the future. You can fertilize the eggs if you want. You can just freeze the eggs. Down the road, you can thaw all the eggs, partial eggs. You can use donor sperm. You can use your partner sperm. You can do, so many options. It really just keeps doors open. It's also possible that you get pregnant on your own and you don't actually need them. But if you do, that's what they're there for. And they can be stored for a super long time. So longer probably than you want to use them. As far as IVF, what is the difference? So it's the same thing as egg freezing. You take the meds, you grow the follicles, we watch you, you have the egg retrieval. And then instead of taking the eggs out and freezing them right away, we use the sperm and we fertilize them. And so the fertilization occurs the same day, and then the embryos grow. So we have to look for signs of fertilization. It takes about 5 to 7 days for the embryos to grow to reach the stage called the blastocyst stage. And it's at that point then that we can do genetic testing on embryos should it be desired. So the genetic testing on embryos is called PGT, or pre-implantation genetic testing. And that can be really advantageous to many, many people because we're able to look to see if the chromosome number is correct in that embryo. We also get information on gender if that's something that's important. But we know that the number one cause of miscarriage is genetic issues. And so knowing that we have a genetically normal embryo, it increases your chance of having a successful pregnancy. I can't guarantee that you always produce it, but knowing that you have a genetically normal embryo really gives you the best confidence going into the embryo transfer. Going back to third-party reproduction. So again, that's when you use any sort of donor gamete. So that's either eggs or sperm. If you use a surrogate or a gestational carrier to carry the pregnancy, that's also under this third-party umbrella. And at Kindbody, we are happy and more than willing to help facilitate that. We actually have our own in-house programs, and we can really facilitate this to make it easier for you because it's hard enough going through it all, let alone having to, coordinate these other moving parts. As far as selecting a sperm donor or an egg donor, there's different ways you can go about it. Kind of getting into some of the nitty-gritty on this is, again, best discussed at a visit. But if you are going to use a sperm donor, you can either use somebody that you know, or more commonly, we go through agencies. There's less kind of legal stuff that goes on there. Same kind of thing for egg donors. You can either have somebody that you know, you can go through an agency. And then for the egg donors, you can also use fresh or frozen eggs. And so there's different ways to go about that. For a gestational carrier, you obviously would be using somebody that would be a surrogate in that case, or if you are going to carry, or if you're using what's called reciprocal IVF, your partner carries. So again, there's options. Our team, thinks of it as like the house that the baby grows in, if you will. And so it can either be yourself, it can be your partner, it can be a surrogate. We're happy to work with whatever your goals are. So just kind of breaking it down again, treatment options are, if you're just planning to preserve your fertility currently, freeze your eggs, think about these options down the road. More currently, if you're actively trying to get pregnant, you can do something like an intrauterine insemination, which I didn't talk a lot about, but essentially we help, make sure that the egg's in a good place. We make sure that it ovulates, and then we get the sperm, we concentrate it, put it directly into your uterus, so it gets as close to the egg as possible to help optimize the fertilization and the chance for pregnancy. Again, we can use donor sperm if needed. There's also the option of doing what's called ovulation induction, which is where we give medications to you to help the eggs grow, and we compare that with an IUI. And then, of course, there's IVF, which we talked a lot about. Again, you can use donor egg, donor sperm, whatever is needed to help you build the family of your dreams. So whether you're trying to get pregnant now or in the future, or if you don't even know and you're just kind of wanting to explore, I highly, highly encourage you to set up a time to talk to a doctor. I am a big believer, knowledge is power, empower yourself, learn about your options, learn about, where you currently stand. I'm more than happy to walk you through things. Even if you're here and you watch this and you want me to go through things again, I'm totally all about it. I want you to become empowered, to know where you're at, and to make decisions with all the knowledge that you need. We have tons of Kindbody clinics all around. So you can see here, these aren't even the ones that are going to be opening. Like I said, mine's going to be down here in Southern California in Newport Beach, but I'm currently hopping out in Century City and Santa Monica and the Bay Area. So there's lots of fantastic, wonderful doctors that are here to help you wherever you may be. And with that, I will answer any questions that you guys have. I hope this has been helpful, and please jump in the chat and let us know what else there is.
Thank you, Dr. Sundheimer, for such an amazing presentation. That was such good information there, and we appreciate it so much. I'm going to start off with this question because it comes up so often. How long should we be trying to conceive before reaching out to a medical professional?
Great, great question. So this comes up a lot, and I think there's kind of the reality of it, and then, what the recommendation medically is. So a lot of people will want to try on their own. A lot of people maybe have irregular cycles. So it kind of varies. I would say if you have regular cycles and you're able to time your intercourse and you're able to detect your ovulation, you feel like you're doing a great job. If you're under 35, then it can be up to a year. If you have concerns about any of those things, if you know you have endometriosis or PCOS or whatever, you can always come in for an assessment, for testing, whatever may be the case, because again, knowledge is power. As you get older, though, that time frame shrinks. So if you're over 35, I wouldn't recommend trying for more than 6 months. And if you're 40 or older, some people will recommend coming in right away, just because we don't want to waste time. What if we find out that your tubes are blocked and that you'll never be able to get pregnant naturally? You don't want to waste those valuable reproductive, months trying on your own if it was never meant to be that way anyway. So I think, those are kind of the cutoffs. It really depends. If you have any questions, I'm sure the provider would be happy to talk to you, just to make sure that you know that you're getting the answers that you need.
Thank you. Another great question that we have here in the chat is, does having less of a period mean I'm not as fertile? I tend to have very light periods and sometimes do not bleed much at all.
So not necessarily. The period that you bleed has to do with the lining of your uterus. And some women just don't have thick linings. You can still get pregnant even though your lining is on the thinner side. We have kind of goals that we aim for, but I've definitely had people get pregnant outside those kind of ideal goals. Also, if you're on birth control pills, that can make it lower. Maybe if you stop birth control pills, it may be more normal. So there's things that can influence it. If you're really concerned, you can talk to your doctor. We can do ultrasounds and things like that, make sure there's no scar tissue or anything that could be causing an abnormality, but it really just depends.
Thank you. Another question we have here is, how do you feel about supplementing CoQ10, DHEA, omega-3, folic acid, and vitamin D? Do you recommend this for women who are trying to improve egg quality?
Yes. I'm of the mindset that most of those things, I don't remember the whole list, but most of those things are not anything that's really going to negatively impact you. So coenzyme Q10, I think is great. It's an antioxidant. It can help with so many things. I think the other one was DHEA. That one I think is in select people. So I would talk to your doctor about that. Some people do have side effects from that medication. So I would, again, talk to your provider. Vitamin D, I think, is helpful. A lot of women are vitamin D deficient. Might want to discuss, checking your levels before you just start something to make sure that you are deficient and you need it. And then folic acid, absolutely. If you're trying to get pregnant, I think all women actually who are reproductive age should be on folic acid or a prenatal vitamin. It helps your hair, skin, nails, and it's really important for the baby's brain development. So I think that it's important to get that on board, even if you're not actively trying. If there's a chance you could be pregnant, you should be on a prenatal vitamin.
Thank you. Another question we have here is, does family history on the male or female side make the most impact on fertility, or is it equal?
It kind of depends. So for women, the age that your mom went through menopause is your biggest predictor of when you go through menopause. So if you know that your mom went through early menopause, you may want to get checked out sooner because you may have lower numbers. For the guys, it's a little bit less, unless there was some sort of known genetic condition or something like that. But I think, we have more to test in women. Of course, as women, we're more complicated. So there's more that typically goes into it. Doing the semen analysis for the man, if everything looks good, then that's kind of the most that goes into it. We do genetic testing that we can offer, but a little bit less so for the male history, although of course there are caveats to that and there are potential important things.
Thank you. And we have another question here. If I am over the age of 35, this fertility assessment does not really help me make my decision of egg freezing, because no matter what the result is, the earlier, the better. Am I right?
So if you want to freeze your eggs, I think I always tell people, I've never had anybody tell me they wish they waited longer to freeze their eggs. So if you're thinking of doing it, do it. People are always so happy they did it when they did, or they wish they did it sooner. But I wouldn't necessarily wait. If you want to do it and you're over 35, I absolutely recommend it, because when you do it when you're younger or at your current time, you're more likely to get more eggs. You're more likely to get healthier eggs. Again, we don't have a way to tell you that at the moment, but just basing it on your age, younger is better.
Thank you. Another question we have here is, I went to get checked earlier this year and was told that my AMH levels were extremely high. The number was 22. Can you explain what I can do to lower that? Thanks in advance.
Great question. So AMH is not necessarily something that we can change. It is a hormone that's secreted by the small little follicles in your ovary. And so it is kind of just what you have. It may just be that you have a lot of eggs. If you're young, it may be that you have PCOS. So you can talk to your doctor about what potentially it means. But there's not anything that you can necessarily do to lower it per se.
Thank you. Another question we have here is ICSI the only fertilization option for eggs that are already frozen? If not, what are the other options, and what are the pros and cons of each method?
Yeah, good question. So ICSI is the only option for eggs that have been frozen. In the egg freezing process, it changes the outer shell and like the normal kind of milieu, if you will, or the normal way that the egg is. So you have to use ICSI, which stands for intracytoplasmic sperm injection, for those who don't know. And that's where they push one sperm into the egg. And so you have to do that because normal fertilization is not possible once an egg has been thawed.
Thank you. And someone here is asking if you could please explain the difference between IUI and IVF.
So IUI, intrauterine insemination, we put the sperm directly into your uterus, and it has to swim through the fallopian tube, find an egg, and fertilize the egg in the fallopian tube in your body. So that is for somebody who wants to get pregnant right now, has open tubes, has normal sperm, if you will. The main difference is in IVF, you are not getting pregnant in the body. Fertilization is not occurring in your body. So we take the eggs out of the ovaries, we put the sperm together with the egg in the lab. Fertilization and early embryo growth occurs in the lab, and then we put the embryo back into your body at another point. So that's why we can grow more eggs, we can control more things, because we're just getting all the ingredients, if you will, and we're mixing them up in the lab to get the end product and then putting it back into the oven to cook. If you're doing an IUI, then we're putting all the ingredients in and cooking it all at the same time. There's no kind of separation.
Thank you. And we have a great follow-up question here. It says, if someone had an ectopic pregnancy, would you recommend IUI or IVF?
It depends. I think, ectopic pregnancy, having had one in the past, does put you at risk for another one. When we do IVF, we can bypass the fallopian tubes. So like I said, we take the eggs, we take the sperm, we fertilize the eggs, we can put the embryo back directly into the uterus. It does not require your fallopian tubes. So if you have severe tubal damage or you had your tubes removed, you may want to, or you may need to do IVF, because we don't need your fallopian tubes for IVF. That doesn't mean you can't get an ectopic pregnancy with IVF, but it does decrease your risk a little bit. That being said, could you still get pregnant with IUI? Absolutely. So both are options.
Thank you. Another question we have here is, what advice would you give women with low AMH and low follicle count?
Freeze your eggs if that's what you're looking for, or do whatever sort of treatment you can, depending on what your goals are, because we know that typically AMH and A count does not go up with time. It only really goes down. So if you're not ready for a family, or if you're trying for a family, I would recommend, preserving your fertility or being aggressive to kind of try and meet your goals sooner if you can.
Thank you. Someone is asking, how does birth control affect how eggs are released?
So birth control prevents ovulation from occurring. And so it keeps your hormones low. So that LH hormone I said that surges and it causes the egg to release, it kind of keeps all your hormones at a low point so that you don't grow an egg, you don't ovulate an egg. So it prevents you from releasing an egg. It prevents ovulation from occurring.
Thank you. Another question we have here is if my cycle is close to 40 days, no birth control ever, is this indicative of a lower ovarian reserve?
Not necessarily. It is outside kind of a normal range. So you probably maybe you just naturally have longer cycles, or maybe you want to get an evaluation to kind of find out what's going on. It is possible sometimes women who have longer cycles or irregular cycles, you're not actually releasing an egg in a predictable manner. You're not ovulating. So in that kind of case, it's probably worth getting checked out to make sure that you are in fact releasing an egg, so that you can help kind of time when to try. It doesn't necessarily mean that you're infertile, but it may mean that you aren't releasing an egg in a manner that's predictable and easy to kind of anticipate.
Thank you. We have another question here. Can you expand upon the process of legitimizing your clinic and how to know who is safe to use?
So I think, obviously you have to feel good about where you're going. You have to feel that you trust your physician and your care team. I think obviously fertility care and, trying to get pregnant are very personal, very intimate things. So you want to make sure that you feel like you have a good bond with wherever you're going. I can say personally, I've worked at other fertility clinics. I think Kindbody is fantastic. It's very, female focused, patient centered, and very warm, welcoming, want the best for you. And I can say that that's true of all of our clinics. And I certainly think that you need to make that decision of what's best for you. But having been at other clinics and being a provider at other clinics and knowing how other clinics work, I think that Kindbody is really top notch, and I highly, highly recommend it.
Thank you. Another question we have here is, if you freeze your eggs and decide to have a baby a few years later, would you always advise them to use the frozen eggs, or is it better to try naturally first?
No, I think it's up to the individual to decide, but a lot of people will freeze their eggs, and then let's say they're like, okay, we're ready to try now. I found the partner I want to have a baby with, whatever. You can thaw those eggs if you want, or you can try on your own and keep those eggs frozen for the future. It's a personal choice. There's no right answer. There are some pluses and minuses, going either direction. But I think, there's no right or wrong answer to that question.
Thank you. And can you let people know what the risks of IVF are, if there are any, and how long does PGT take?
So IVF risks, there's risks for everything. So there's never anything that's without risks. So the risks with IVF are, you can potentially not get any eggs. You can get a lot of eggs, and it can actually get to the point where it's dangerous, something called OHSS, or ovarian hyperstimulation syndrome. That can be a very severe and complicated course. So some people will be like, get as many eggs as you can. I want as many as I can. I never want to do this again. Which, of course, I want you to get eggs. I want you to not have to go through it multiple times, but I also have to be safe. And your safety is number one for me. So we have to do it in a safe manner. It's possible, the procedures that you go through, there's risk for anesthesia. You can have bleeding. There's a small chance of infection. So there are risks from procedures. You're giving yourself shots, which, you can get bruising or little irritation and things like that. But most people will complain of like bloating or fatigue or pelvic pressure, maybe constipation. But a lot of people do really well. So I think you got to kind of keep it in mind that any sort of major complications is less than 1%. And we do this procedure every single day. And the vast, vast, vast majority of people do great. And then as far as the second part of the question for PGT testing, it takes about a week for the embryos to grow, and then it takes a couple more weeks after they do the biopsy to get the results back. So a couple weeks usually.
Thank you. Another question we have here is, does Kindbody require a referral from a primary care provider for egg freezing?
Nope, not at all. You can book an appointment here today. I'm happy to see you.
Thank you. And then we have another question here. At age 40, how quickly is egg quality declining month to month?
So every woman is different. There's no kind of like this month it goes down, that month it goes down. So it's just kind of a general thing where we just know that there's like a percentage of the eggs that are not good. We're looking for the good eggs, and I don't know exactly if it's going to come up this month or next month or 4 months from now or whatever. So it's not like there's kind of a very clear decline, but we just know, generally speaking, that the decline does go up in the mid to late 30s.
Thank you. Can you talk a little bit about the recovery time after egg retrieval? How long does it normally take?
Yeah, so usually women, like I said, you're growing more eggs than normal. So you're going to probably feel a little pelvic pressure, heaviness, fullness, that type of thing. It takes about 2 weeks for them to grow, and it's going to take a little time for them to shrink back down to normal. So I would say most people after a week or so are kind of feeling back to themselves. But typically once you get your period following, then your hormones should reset. You should be kind of in a good place. So you don't have to be on bed rest or anything like that unless your doctor tells you otherwise. But usually you just plan to kind of lay low, take it easy. But you're doing your relatively normal activities.
Thank you. Someone else is asking, what issues could someone have if their period is normal every 26 days and they ovulate, but they don't conceive? What would be best, IUI or IVF?
So you actually need to get an assessment and kind of do more testing. There could be other things at play. It's not all about just the ovaries. So from a fertility perspective, you also want to look at the fallopian tubes and the uterus, and then also the sperm. So the result of that testing can help determine what the best treatment would be.
Thank you. Another question we have here is, does PGT or PGS cause any harm to the embryos?
So no, so that we've been doing PGT testing for a long time. It used to be called PGS. Now the kind of terminology is PGT testing. It's not required. So if you have concerns, you don't have to do it. The vast, vast, vast majority of embryos are unharmed. I think obviously, we want the best for you. We treat your embryos with the most care and precision as possible. And so we do our very best to minimize any sort of damage. It is possible on a theoretical level, but I would say that I don't think I personally have had any embryo not survive PGT testing.
Thank you. Another question we have here is, why would AMH change 5 points from 10 to 5 within 6 months?
So there can be different labs that have variations in their assay or the way that they check the hormone. So it may be worth actually repeating that test at the same facility, or maybe doing like a third one as a tiebreaker kind of thing to see if it's more on the 10 side or the 5 side. Having an ultrasound is also helpful. It's not necessarily, it's just kind of a marker that you're in a higher range. It doesn't necessarily mean, that this number of follicles corresponds to this AMH level. It just kind of gives us a general sense.
Thank you. Another question we have here is there an age limit on implantation after egg freezing and fertilization?
So there are cutoffs. It can be clinic specific. I believe most people will allow you to use the embryos into your early 50s.
Thank you. And are there any side effects to the medications that are taken before egg retrieval?
So like I was saying, a lot of people experience like bloating, fatigue. Sometimes people get a little bit headache, but mostly it's just kind of feeling that your ovaries are enlarged and maybe some constipation that goes along with that.
Thank you. Someone else is asking, they're looking to do multiple egg retrievals for IVF. Is it better to wait a period of time between retrievals, or is it safe to do multiple months in a row?
Medically speaking, you can do it back to back. Sometimes your body needs more time to recover. Sometimes IVF can be just hard on your body and, your time and your schedule and giving yourself shots and things like that. So you can go back to back, but I would talk to your provider and just make sure that your ovaries look like they're ready to do another cycle and you mentally, physically, emotionally feel ready to do it as well.
Thank you. Another question we have here is, if you have fibroids, but they're not in the uterus, can that affect IVF?
It depends on the location of them and the size of them. So some women, if they have really big fibroids, we have to be able to access the ovary through the vagina. And if there's a fibroid that kind of gets in the way, then yes, it can impact things. Generally speaking, most women have fibroids that aren't big enough to do that or in a location, but it is technically possible. So that would be something at your ultrasound that we would want to make a note of and kind of just look at the location of your fibroids and the size.
Thank you. And how can someone increase vitamin D if supplements are not helping? Would infusions or injections help?
So there's different levels of supplementation that you can take. There is, over-the-counter supplements. There's also prescription supplements. You can increase your diet in vitamin D rich foods. Being out in the sun can help too. So there's other ways to do it. If you're severely vitamin D deficient though, then you should talk to your doctor. Maybe you do need some sort of prescription strength supplementation.
Thank you. Someone else said, if you have frozen eggs, can you use them even after menopause?
Yes.
And what factors affect how many eggs are released in a month?
So it's kind of complicated. We don't really know 100%. Typically, most people will just release one. Sometimes there can be more than one. As the FSH level goes up, it's kind of a known thing that women in this like perimenopause kind of time can maybe release more than one. But typically in a normal unfertility treated unmedicated menstrual cycle, usually release one.
Thank you. And are there any medications that can affect egg quality? Is there anything that someone should avoid that can impact egg quality?
There are certain medications that we do not recommend. It's very specific circumstances. So if it's a specific question, this is kind of, too nuanced, I would say, to get into like a major group chat. So I would talk to your specific doctor about your questions. Taking like Tylenol, Advil, that kind of stuff should not, the over-the-counter common stuff should not necessarily impact things.
Thank you. And can you talk a little bit more about PGT? Can you explain for our audience members who don't know what that is, what it is, how it's done, and what it can test for?
Yes. So PGT testing is pre-implantation genetic testing. That's the umbrella term. There's different types of testing that we can do within it. So there's PGT-A, there's PGT-M, and PGT-SR. So kind of just going step by step, the most common one that we do is called PGT-A, which is PGT screening for aneuploidy, which stands for essentially looking for the number of chromosomes. So the way that is done is the embryo grows, and when it gets to the blastocyst stage, the embryologist can remove a few of the cells. It has hundreds at that point, so it's not impacted. And then we freeze the embryo and we send off the cells for genetic testing. This is true of all PGT testing, but when you're doing PGT-A, we're looking for aneuploidy, we're looking for the number of chromosomes. So it can tell us if each embryo, if it has the right number of chromosomes or if it has an extra or it's missing. We also get information on gender. PGT-M stands for monogenic disorder, which is a single gene disorder, and it's looking for specific diseases that we would have to know that you're at risk for passing on. So sometimes we'll offer something called genetic carrier screening. If, let's say, you and the sperm came back positive for this condition, then we want to screen the embryos for that condition, we would do PGT-M. We only can do that in certain cases, and it's a whole separate level of testing. So we could go into details on that in an individual visit, but just so you know that it's out there. And then lastly, PGTSR is for structural rearrangements. That's for somebody who has a genetic condition in their chromosomes. And so we can look for that in embryos. Again, something to talk about one-on-one if you desire, but the main one is PGT-A, which looks for the genetic composition of each embryo.
Thank you. And we're almost at time here, so we'll take one more question. Can you please talk about adding immune protocol to a cycle if there is recurrent implantation failure?
So recurrent implantation failure is hard. I think it depends on your physician, it depends on your testing, it depends on, your history. So that's kind of a nuanced question that's probably a little too narrow for the purposes of this discussion, but there can be some helpful things that can be done. Again, sometimes we just do things empirically because we want the best and we don't know exactly what's going on. So it's hard to say.
Thank you, Dr. Sundheimer, and thank you all for joining us tonight. We hope that this was helpful to you and that you learned something from it. If you have any other questions that we didn't get to in the chat, you can always email us at navigator@kindbody.com, or you can send them to us via direct message at Kindbody via our social sites. We're on Instagram, we're on Facebook, and you can also reach out to Dr. Sundheimer. She did share her social media sites as well. You can always, like I said, email us at navigator@kindbody.com if you have any questions, or if you want to book an assessment. And if you want to book an appointment directly with Dr. Sundheimer, you can email us and ask for that as well.
Yes, thank you guys all. Good luck to you, and I'm wishing you the best. If I can help you at all, let me know.
Thank you all. Have a great evening.
Bye, everybody.
Bye.